My name is Krishna, and I'm a professor of medicine at the Ohio State University Wexner Medical Center. Here I'm presenting a recent publication in gastrointestinal endoscopy. The title of the study is Interobserver Agreement in Dysplasia Grading of IPMNs, Performance of Kyoto Guidelines and Optimization of Endomicroscopy Biomarkers through Pathology Reclassification. Over 50% of resected branch duct lesions show only low-grade dysplasia, indicating overtreatment of IPMNs. Here are some key differences between low-grade dysplasia and advanced neoplasia. In low-grade dysplasia, the papillae are typically small, occasionally layered, and often appear flat. Whereas in advanced neoplasia, the papillae are significantly larger and frequently occupy the entire view. Moreover, in low-grade dysplasia, the papillary epithelium is thin, sometimes flat and translucent, reflecting the absence of significant cellular and nuclear stratification. In contrast, though, in advanced neoplasia, the epithelium becomes thick and dark, indicating pronounced cellular and nuclear stratification. There are limited inter-observer agreement studies among surgical pathologists in dysplasia classification in resected IPMNs. The few published studies show that there is low inter-observer agreement among dedicated pancreatobiliary pathologists for dysplasia classification in branch duct IPMNs. We conducted a study among experienced pancreatobiliary pathologists to assess the concordance of dysplasia classification in resected IPMNs and resolve discordant cases, establishing a consensus histopathological diagnosis. Moreover, we compared these classifications with the pre-surgical endomicroscopy dysplasia classification and also compared it to the high-risk stigmata from the most recent Kyoto guidelines. In this study, we included 64 consecutive patients with resected branch duct lesions from 2 prospective studies at a single center. 2 dedicated pancreatobiliary pathologists reviewed all the pathology from these resected lesions and classified the dysplasia. For discordant cases, the pathologists jointly reviewed slides utilizing deeper sections and immunohistochemical stains when necessary. If there was disagreement after immunostaining, this was resolved by a third expert pathologist. Finally, we had reclassified histopathology for all the resected IPMNs. Here are the study results. In the 64 resected branch duct IPMNs, the mean size was 3.5 centimeters. There was substantial inter-observer agreement among the 2 pathologists for classifying dysplasia. For endomicroscopy, the accuracy to differentiate dysplasia was 80%. And the Kyoto variables had a similar accuracy where sensitivity was low and specificity was high. When combining the Kyoto guidelines with endomicroscopy, there was a good balance of sensitivity and specificity with an accuracy of 81%. A part of the study was trying to understand why endomicroscopy would not be able to predict dysplasia accurately. There are 2 concepts. Endomicroscopy undercalling the presence of advanced neoplasia. Here, endomicroscopy findings include thin flat papillae suggestive of low-grade dysplasia, whereas in these cases, histopathology revealed pancreatobiliary type epithelium with high-grade dysplasia characterized by low-profile epithelium, complex micropapillary architecture, and small bland nuclei showing stratification. These lesions were most commonly located in the body or tail of the pancreas compared to the head or uncinate process. All undercalled cases exhibited a micropapillary architecture with short papillae lacking true fibrovascular core. In cases where next-generation sequencing analysis was available, all undercalled lesions had KRAS mutations without accompanying GNAS mutations. In most of these cases, there was absence of main duct dilation. In regards to the concept of overcalling of advanced neoplasia, here endomicroscopy findings would include large papillae with thick dark epithelium, suggestive of high-grade dysplasia. On the contrary, histopathology would reveal large papillae consistent with low-grade gastric type epithelium. We found this in 5 cases, and they were situated in the head or uncinate process of the pancreas. There are some key discussion points and implications of this study. A second pathologist review is recommended for dysplasia classification in branch duct IPMNs. There is a 20% discrepancy between pre-surgical endomicroscopy and final histopathology. The undercalls for high-grade dysplasia are associated with a micropapillary architecture, and these lesions are predominantly located in the body and tail of the pancreas and tend to have only KRAS mutations. Whereas the overcalls for dysplasia, these lesions are located in the pancreatic head or uncinate process. Combining Kyoto high-risk stigmata with EUS endomicroscopy significantly improves sensitivity while maintaining accuracy, highlighting their complementary roles in preoperative risk stratification. These study findings have direct implications because they'll be used to refine the preliminary AI models for accurate classification of dysplasia and IPMNs.